Hi, everyone. This is Robin Carlson with Stratus Health, and this is the second session in our abstraction training. And what we'll be talking about today are the outpatient measures, the CMS outpatient measures. It will be me today doing the talking, and along with us on the presentation is Jody Winters, and she'll be helping me kind of monitor the chat and be my person to tell me, yes, we can see this screen, we can see that screen, because I'll be kind of shifting around and doing screenshots. So give me a little leeway if I mess up, even for as much as we've been doing Zooms. Sometimes I think I'm clicking on the right thing and it doesn't always show. But if any of you have listened to my other talks, you know I am a pretty informal presenter. I really want this to be just like we're having a chat. I want this, to be, this is for you guys. I want you to make sure and understand what I'm talking about. So if you have any questions, you can unmute yourself and speak up. We'll definitely have time at the end for questions, but as I'm going through, if you have a question right then, sometimes it's easier to ask it while you're thinking about it. Or you can put it in the chat. And Jody, I'll ask you to kind of look at the chat and just interrupt me if there's anything. So that's kind of the plan for today. First off, what I want to do is bring up the the agenda, is pretty clear. Just going to show you how to find the specifications manuals on QualityNet. Then we'll talk about the AMI measure. We'll talk about the ED-Throughput measure. The population, so you know which records you have to do, if you can sample, talk about the population and sampling, and then talk about some of the data elements that might be a little more difficult than others to go over. So I'm going to stop screen sharing for a minute and then pull up the QualityNet page. Okay, Jody, do we have the QualityNet page?
Yes.
Okay, thank you. All right, everybody, hopefully you're all familiar with this page. This is the main page of QualityNet, qualitynet.cms.gov. So even though there's been, that change, and you have to have a HARP account to enter your data, and you're entering it into hospital quality reporting, this site in QualityNet is still here. It still exists. And it is our site for finding the specifications manuals, for finding the CART and the CART versions. And we'll talk about that in the next session next week if you've signed up for that. But you still need, this is a great site to bookmark. You still need this site to be able to find some of the information that we need for abstraction. And while we're here, I'll just give kind of a plug about, it's really important to subscribe to email updates, because this is the way that CMS sends us out information about their programs. So to learn that there's a new manual, to learn that there's a new version of CART, if they've got updates about when things are due, if they've got something about QualityNet is going to be down or something. If you don't subscribe to the email updates, you might not get that information. And it's pretty simple. All you have to do is put your name in your email. Okay. Now, if a lot of you who've been doing this for a long time have probably already done this. They used to maybe call it something different, but if you're getting the emails from CMS, then you've already signed up. But for anybody who's new on to abstraction, you want to make sure you come in here and sign up. Now, there's a lot of things you can sign up for, but the ones, if you are an abstractor and submitting data to CMS, I would sign up for any HARP notifications, any QualityNet notifications, about record. If you're using CART, I would sign up for the CART tool. If you want information about hospital outpatient reporting, scroll through and see what you might feel that you need. I will tell you that a lot of these programs put out the same information. So you might get the information maybe 4 or 5 different emails. If you're like me, I would rather get more information and delete it than maybe miss something. But I think at the end of each email, it always tells you how to get off of the list if you're not interested. So again, this is the way CMS sends out information. So it's important to get on the list for some of the programs that you use. Okay, I'm back on the main page, right, Jody?
Yes.
Okay, so what do we want to do is find the manual, okay? The specifications manual for outpatient measures. And even though we are talking about doing this abstraction for the Mbqip program, the outpatient measures in the Mbqip program are the measures that are part of the CMS program. Okay, so we use the instructions for those measures. If we were submitting data for the CMS outpatient program or for Mbqip, it's the same measures, it's the same instructions. So we're going to look for outpatient. And there's a lot of other information in here, you know, on QualityNet, and you're perfectly, in all of your downtime, you can look through and see the other information on here, but we're just talking about the instructions for the abstraction of the measures today. So I'm going to click on View All Manuals. Now, the reason this pops up is because in the manual, there is some CPT information. And so because of that, we have to agree to be able to look at that. But this is the page with the manuals. It's always going to pop up when you come over here. It's probably going to pull up the most current manual. And CMS just put out this manual for 2023.
This is Janice.
Okay, just a reminder that you guys are not on mute unless you put yourself on mute. Okay. Unless you have a question. So I didn't mean to interrupt that person if they had a question. But we want to make sure we've got the manual for the time frame we're abstracting. And what's coming up, the next time frame for abstraction, what's due is Q1 of 2022. So we don't want instructions for 2023. Okay, there could be changes from the 2022 version, and we don't want to abstract using instructions for a time frame that we're not abstracting yet. So we want the version 15.0A. Okay. Now, here's the manual and all of its different sections. The thing to note is that CMS does what they call release notes. And what release notes are, release notes tell you what is different from the prior manual. So release notes for this version 15.0A will tell you what is different from that version that was in 2021. And that's the way you know. Okay, that is the only way that you know. So it's up to you when you're starting a new manual year, like now, Q1 of 2022 is due in August. So if you haven't started abstracting yet, what you want to do is go through these release notes to see, okay, what is different from the manual that I used in 2021? Might be barely nothing, might be a lot of stuff. You need to look at the release notes. Now, release notes kind of really, they're enough. Well, I'm going to pull them up and hopefully we'll see what happens here. Okay, release notes, here there's 11 pages. Okay, it really tells you everything that's different from the manual. I mean, every little thing, like here, they changed a word. Okay, it's a lot of stuff that it might not even pertain to you that much. Okay, but that's what release notes It tells you everything that's different from the last time. Okay, I'm gonna get out of here. I want to go back to here. Okay, now you'll note there's two different sets of release notes because CMS puts out manuals pretty early. Like you know, we're just going to do Q1 of 2022, and they've put out the 2023 manual. So they might have more than one version of release notes. So that's why here there's the 15.0. That was the first, letting you know what it's changed from the 14.0 version. But then they made some other changes. So then there's another release notes, 15.0A. They might have another, you know, before once we get to the 16, they could be A, B, C. Okay, you just need to keep looking and check and make sure you go through all of the release notes. So that's what release notes are about. Tells you what's different from the last manual. Then the manuals are set up the same. You know, every manual has table of contents, the different measure sections. Now remember that these are CMS manuals. So all of the CMS outpatient measures are in here. Okay, now we are talking about what's needed for the Mbqip program. So I'm only talking about the AMI and the ED-Throughput today. Okay, stroke measures aren't required for the Mbqip program, but you know, perfectly fine that you're submitting them. But because they're not part of the Mbqip program, and that's why I'm speaking with you today, because of the Flex program with the Minnesota Department of Health, I can really only address the measures for the Mbqip program. But this is a CMS manual, so all of the CMS measures are in here. These are the measures that are the claims-based measures that CMS has. We've got their outcome measures, the web-based measures, data dictionary, which we'll go over, population and sampling, which we're going to talk about, some tools and resources. You know, we'll talk about the different sections, but mostly we want to talk about the abstraction of the measures today. So any questions about QualityNet or anything? Okay. So we're going to talk about the AMI measure set. Okay, now there are two measures that make up the AMI measure set, OP2 and OP3. Okay, for this measure set, it's not an either or. You don't say, oh, I'm gonna do OP2, but I'm not gonna do OP3. That's not how this is set up. This abstraction is set up. Okay, there is one population for the AMI measure, and that's how you pull your cases. And how you enter the data, be it the CART tool, or if you have a vendor tool, however your data goes there, how you answer data element questions determines whether that case, does it fall in OP2 or OP3? Does it fall in both? Is it removed from one or the other? You as an abstractor don't do that, okay? You pull for the measure set of AMI, and how you answer questions determines how that case falls into one or both of the measures. All right. Now, when we talk about knowing the first step in this abstraction is, how do I know which records I have to do? Okay. You don't guess. Okay. There's specific instructions that tell you which records to pull for this AMI abstraction. So when we talk about population means which records do I have to abstract for the measure set? Okay. So for AMI, there are the two measures. You are abstracting for both. There's just one measure set pull. And these are the instructions, how you know. Okay, the population for AMI, and that's for OP2 and 3. Patients seen in a hospital emergency department, and for CMS, for abstraction purposes, how they determine if a patient was seen in the ED is that there is an E&M code. And E&M codes are related to billing, kind of like the services that were provided. So that isn't something that you're going to find looking through a record. That's sort of a billing department, but is where you're going to get that information. But again, pretty much everybody who's seen in an emergency department has an E&M code, and that's the key for determining seen in an emergency department for abstraction. So they were seen in your ED, and then there's 3 requirements. They have to have been discharged or transferred, whichever word you use, and people get too hung up on those different words, but it doesn't matter. Discharged or transferred, it's about if they leave your ED and go to a short-term general hospital for inpatient care or to a federal healthcare facility. A short-term general hospital for inpatient care pretty much means you transferred them to another hospital, to another acute care hospital. Usually one that has services, that you don't have, a larger PPS hospital. So they were transferred to another acute care hospital or a federal healthcare facility like a VA hospital. Okay, that's first requirement. Okay, so if they went home, that's not going to fit in the population. Okay, if they went to a nursing home, that's not going to fit in the population. Have to be discharged or transferred to an acute care facility or to a VA hospital. They have to be 18 years of age or older, excuse me, and they have to have an ICD-10 CM principal diagnosis code for AMI that's defined in this table. All right, and I will show you the table. So to be part of the AMI population, they have to meet these 3 requirements. If they don't, you do not abstract them. And maybe some of you have come across this, maybe you didn't really know that this population requirements were here, or you just pulled everybody that was seen in the ED and that they had some kind of an AMI diagnosis. And maybe you were trying to enter them into CART and CART rejected them. And they might have been rejected because they didn't meet like one of these 3 requirements. Okay. So again, discharged or transferred to an other acute care hospital, 18 years of age or older, or having a principal diagnosis code for AMI on this table. And I will show you where to find the table. This is our table of contents of the manual. Okay. If we scroll down to the bottom in the appendices, here's our ICD-10 CM diagnosis table. Okay, the first table are a table of E&M codes. So remember, to be an emergency department patient for this abstraction, they had to have one of these E&M codes. And then this is our table for the AMI. Has to have one of these codes as the principal. Okay. If they don't have one of these codes, then they're not part of the abstraction. Anybody have any questions about that? Now, the one thing that I can't do and CMS really can't do, we can't tell you exactly how you can find out this information. Okay, I mean, we're telling you that what has to be met, but how you and your hospital are able to get a listing of these patients who meet these requirements, that's kind of up to every individual hospital. Do you have IT staff or someone that can, run a report for you to pull these out? That's the one thing that I can't really help. We can't really help you with, because everybody's situation is different. So we can just tell you what has to be met, but how you get these records, that has to be figured out within how your system works. Does that make sense? Anybody have any questions about that? Okay, so we're back in the section for AMI. This is where we got our population. If you're a flowchart person, this is kind of, this is the way, you know, if you got an E&M code, then you look for this, then you look for this. I'm not a flowchart person myself, but, you know, some people really like this visual. It's just the way how you can see how that patient flows through and gets entered. Here's really the narrative of what was above in the flowchart. Leave that to you guys. Here's the measure. Here's OP2. All right. Emergency department AMI patients with ST segment elevation on the ECG closest to arrival time, receiving fibrinolytic therapy during the ED stay, and having a time from ED arrival to fibrinolysis of 30 minutes or less. This is if you want information about the measure, okay? As an abstractor, what you really need to know is what's my population, what do I have to enter, and then how to answer the data element questions. But here's the information about the measure if you want more information on the measure itself. If you're going to look here, and every page of the manual will tell you what the encounter dates are. So you've got that there. This information here about included population and excluded population, don't get this mixed up with your initial population. The initial population meet those 3 requirements. Those are the records you enter. There's no ifs, ands, or buts. Those are what you enter. This information will tell you, depending upon the data element information you enter, is that patient going to be included in OB2 or are they going to be excluded? Okay, you do not include them and exclude them based on this. Okay. Your tool for abstraction will do that depending upon how you answer the questions. But this is just for information if you wanted to know about OP2, which patients end up being part of that population. You abstract everybody that meets the initial population. How you answer the questions, how you answer the data element questions determines if patients are included or excluded. Okay, does that make sense? I don't want to confuse anybody, but I know sometimes we have people who will pull out patients after looking at this, and that is not correct. More flowchart, blah, blah, blah. And then here's OP3. The median time from emergency department arrival to time of transfer to another facility for acute coronary intervention. Again, you don't worry about A, B, or C. You abstract those patients who meet those 3 requirements at the beginning, and then how you answer the questions determines whether does that patient go in the overall rate? Is it in the reporting measure? Is it in the quality improvement measure? Okay. And here's just more specifics on the measure itself. Any questions about AMI? Everybody would know how to do the population, so they know which records they have to do. Okay, I am going to take that for a yes. Okay, those are AMI. You know how to do the population. We're going to go to ED-Throughput. There's 2 measures that are part of the ED-Throughput measure set. But in this instance, there's only one. OP18 is a quarterly measure. And I'm sorry, I should have mentioned that for the AMI, but those are quarterly measures, chart abstracted quarterly measures, so they get submitted every quarter. OP18 is the quarterly measure for ED-Throughput. OP22 is a yearly measure, and we'll talk about that in a minute. But OP18, median time from ED arrival to ED departure for discharged ED patients. So what's the first thing you need to know? What's my population? So scroll down a bit. Population, patients seen in the emergency department, so they have that E&M code, are included in the OP18 hospital outpatient population and are eligible to be sampled if they have an E&M code in that appendix. And if you can remember, when we were back on that appendix page, that first table was the E&M codes. So the only requirement for OP18, the population requirement, is that they have an E&M code so that they were seen in your ED. Where they were transferred to or discharged to doesn't matter. How old they are doesn't matter. What their principal diagnosis code doesn't matter. Okay. So pretty much your population for OP18 is everybody that was seen in your ED and discharged or transferred or went home or were in your ED and then left. Okay, makes sense? So this is the one where you could have quite a few patients. So let me finish going through a little bit about the ED-Throughput set, measure set, and then we'll talk about the potential for sampling. All right. So here's flowchart, let you go through that, blah, blah, blah. Here's our measure, just the one measure. This one, again, has some different rates to it. There's A, B, C, and D. You don't worry about that, okay? As an abstractor, you abstract those patients that meet that population requirement, and how the data elements get answered determines whether that patient falls in A, B, C, or D. The reason why there are some different ones here is because we're talking about timing here, okay? Time of arrival to time of departure. And some patients, like here, for instance, that 18C is for patients who have psych or mental health diagnoses, because it's known that those patients, sometimes they end up being in your ED a little bit longer because it's not always so clear where those patients are going to go at discharge, or trying to find where to transfer those patients. So they might be in there longer. So CMS didn't want those patients to maybe inflate your ED times, so they took those out of the reporting measure. Same thing with patients in general who are transferred. If you've got a patient that's going home, okay, they're going home. If you've got, there's not a lot of where are they going to go, or is anybody going to accept them, or whereas for transfer patients, again, they might end up in your ED longer because you're trying to figure out where they might be going to. So that's why those patients are removed from the reporting measure. So again, your times don't look inflated because of being transferred. So that's why there's the different measures. But you as an abstractor, you don't do anything about that. It's how the data element questions are answered that pulls the patient in the right set. Okay, then here's specifics to that measure. All right, now the second measure in that set is OP22. The percent of patients who leave the emergency department without being evaluated by a physician, advanced practice nurse, or physician's assistant. This is the one that is a yearly measure, and it is due, it's due in May, and the information that you are going to enter is from the prior year. So, okay, in May of 2022, you enter data for the year of 2021. The next due date for this will be in May of 2023, and it will be data for the year of 2022. The two numbers you need are the total number of patients who presented to the ED, and then the total number of patients who left without being evaluated by the physician, APN, or PA. This is another one of those where CMS tells you the numbers that they want, but how you get that information depends on how it's set up in your system. Okay, the assumption, for lack of a better word, is that hospitals do track on this information. Okay, you track on how many patients presented to the ED, and then you're tracking on those who left before they were evaluated. All right. So again, this isn't going to be due now till May of 2023 for data for the year of 2021. This is a yearly measure, so you're collecting data for the whole year. And we always give you plenty of notice when this information is coming due, because you get out of the habit. It's not like a quarterly measure. So we really put out a lot of reminders when this is due again. Okay, any questions about the ED throughput measures? Okay, so when we were talking about your population, okay, and again, you always know your population. Okay, you have to. Your population is which records do I do? So when we talk about population and sampling, people get a little fuzzy, or maybe they think, oh, it's something else I got to figure out. No, you always know your population, because that's how you know which records to do for the quarter. So you always have that number. Now, the sampling part is if your numbers are large enough, okay, CMS and so the Mbqip program says, well, you don't have to maybe do them all, okay, but you can't choose your sample. So CMS has this section in the manual, population and sampling. All right. So in this section, it tells you population. Basically, it's, again, you can let you read it, but it's figuring out which records you need to do. So you know that. So now it's, can we sample? Now, let me tell you, for your AMI cases, I work with, hospitals kind of across the country in my ARCITA role, and I don't know of any critical access hospital that can sample for AMI cases. You just don't see enough. But how you would know is there's different tables for the different measure sets in this section. So you would, and here talks about, this is sampling. We say random sample. We don't really tell you how to find a random sample. So you need to kind of figure that out on your own. But here's the sampling piece, and I'll let you read all of that. But you want to find the table with the sample size requirements. All right. Now, you can always do as many records as you want. You can always do all of your records. But for the sample size, there is a requirement. You can't just say, I'm only going to do 5. I'm only going to do 2. Okay. The one thing that is different kind of in the CMS measure is that they used to, and I'm not sure if they have this before, but if there were 5 or less, CMS used to say for their measures, you didn't have to submit them. That's not true of the Mbqip program, okay? If you have one case that meets the population requirements, you do it, okay? So you will do everybody who meets the population requirements. If there's 1, if there's 10, whatever. You can do as many as you want, but there is a minimum for your sampling. So OP2 and 3, those are the AMI. Okay, so this would be the table we would use to determine the sample size for the AMI. So here you can see if you have 80 or less for a quarter, you would do them all. So pretty much you're going to do all of your AMI cases. Okay, but here's your table for determining that. Okay. And it goes on because remember, this is also for you, the large PPS hospitals. But we want to find our sample size for OP18. Okay, and here it is. Now, this is the one where potentially you could have a pretty big number, because remember we said the population is everybody pretty much that was seen in your ED that has that E&M code. So this might be the one where you can choose to sample. So if your population for the quarter is between 0 and 900, you see between 0 and 900 cases in your ED for the quarter, your minimum sample size is 63 a quarter or 21 a month. Okay. Now, if you have less than 63 for a quarter, you would do them all. If you had 50, you would do 50. Okay, but your minimum, if your population is is up to 900, is 63 for the quarter, 21 a month. If your population is over it's 901 or over, then your sample size is your minimum is 96 for the quarter and 32 a month. Okay, so this is population and sampling. You always know your population because that's how you know which records to do. And then you know your sample. If you're doing them all, then that's the same as your population. If you're not doing them all, then what's your sample size? How many are you doing? Your sample number is the number that you are actually submitting to CMS, to the hospital quality reporting. Okay, so you know these numbers all the time. So when we ask you to do and fill out that population and sampling, you always know these numbers. I guess the extra, if you wanted to put it that way, is putting the data in the population and sampling section in hospital quality reporting asks you to which are Medicare and which are non-Medicare, but you always know these numbers. That's your population and sampling. Anybody have any questions about that? Okay, and usually again, no sampling, you're doing all of them for the AMI, but your ED-Throughput might be the one where you have enough cases that you can sample. While I'm thinking about it, maybe some of you have heard that the AMI measures, CMS is retiring the AMI measures, but that is not until after Q1 of 2023. So for all of 2022, we are still all of 2022 and Q1 of 2023, we are still abstracting the AMI measures. Okay, they are still part of the Mbqip program, and the expectation is that you would be submitting data. The AMI are the one measures that maybe sometimes you don't have any cases. Okay, and that is another reason why. Now, if you have no cases, what is your population for the AMI? It would be 0. What's your sample size? It would be 0. That's what you would put in for your population and sampling. And then your Mbqip reports would it would reflect the fact that you had no cases. So I wouldn't just see an NA on there and have to call you and wonder why you didn't submit anything for that quarter. If you put data in for the population and sampling, then we would know. It shows up on the report with, I believe it's an asterisk now. That means you had no cases for the quarter. So your report would accurately reflect the fact that you had no values because you had no cases. You had no numbers because you had no cases. Does that make sense to people? That's why we kind of really push the population and sampling. Otherwise, if there's no data in the warehouse for you and no data comes to the report developers, we just know there's no data. We don't know why. Did you forget to submit for this, quarter? Did you just not want to? Whatever. But filling in population sampling lets us know, gives us more information. Okay, there's the AMI measures, there's the ED-Throughput measures. Those are the current measures that are part of the Mbqip program. You know how to do your population, you know how to sample. Now, if we want to talk about the actual data elements, where that information is, it's in the data dictionary part of the manual. Okay, Jody, are we seeing data element list?
We are.
Okay, thanks. Let me say, you guys, while I think about it, everybody's setup is a little bit different these days with their EHR. Okay. We have 77 critical access hospitals in Minnesota. And I will be honest with you and say, I don't really know everybody's setup. I know if you've talked to me about it or if we've had discussions, but I know some people still use the CART tool and then they submit their data. I know that some people maybe have their abstraction is kind of done maybe by their hospital system. It's centralized. I don't know if other people, maybe they're not using the CART tool, they're using a vendor tool. Maybe some people have their data, they've got a system where their data is pulled directly from their EHR, and maybe it's put into the CART tool and then they submit it, or if they submit it directly to CMS from their EHR, everybody's setup could be a little bit different, okay? The one thing that is the constant, no matter what system you use, is that you are responsible, okay? You as the abstractor, or you as who's managing the program in the hospital, you're responsible for the accuracy of the data that goes there, okay? So you don't want to be, either you're pulling the data out of the record yourself, or if someone's developed a system that they're pulling it from a field for you, you need to make sure they're pulling it correctly. Are they pulling it from the right field? Are they following the instructions for that data element? Because if your hospital looks bad on a measure, it's because the data that's getting submitted, it's because of the data that's getting submitted. So you don't want to be submitting the wrong data. If your hospital looks bad on a measure, and not that we want anybody to look bad, but you want it to be because maybe there's a process that needs to be changed or something that needs to be worked on in the hospital. You don't want to look bad on a measure because you as an abstractor pulled the information wrong, or whoever did the program to pull out of your EHR was pulling from the wrong field. Okay. Bottom line is somebody has to check and make sure that data that's going to that hospital quality reporting CMS warehouse is accurate. So these are the instructions for the data elements. All right. And there's not that many anymore, you guys. I mean, for ED throughput for OP18, pretty much other than some demographic stuff, it's just the ED departure date and time. But again, this is all about if these elements don't go in correctly, this is what determines how your hospital looks on that measure. What's the time from ED arrival to departure? Okay, it's because how these are being answered. And so I want to talk a little bit about some of the ones that sometimes there's some discrepancies on. So discharge code. Okay, I mean, it seems like a relatively easy one, but it isn't always, because these are the values for abstraction. They may not match up with your hospital's billing discharge codes. Okay, we don't want your hospital's billing discharge codes. Okay, we see excluded sources like the UB04. We want to know, where did that patient go when they left your ED? And these are our values. Okay, home, acute care facility, critical access hospital. Some places, I don't know how much that maybe happens in Minnesota, but in other states, if you're a relatively small critical access hospital, you might have a closer, larger critical access hospital that you would send to. So that's why it's broken out. If they went to the VA, here you've got your other healthcare facility. So here's manuals are set up with, here's our question, here's our values that we can choose from, and then notes for abstractions are the instructions. How do I know when to pick this or that or whatever? The thing that you want to look at for discharge code here is this gives you inclusions. So value 1, that was home. What's included in home? If they went to assisted living, well, that's value 1 home. If they went to jail, if they went to a homeless shelter, okay, all of those would be under one home. All right, I think the hospitals are pretty self-explanatory, but then we've got that big catch-all other healthcare facility. How do I know what fits under there? I come down here. That's nursing homes. That's skilled nursing facilities. That's swing beds. Psych hospitals. That's all fits under value 5. So you want to use for abstraction these values, which may not necessarily match up with your discharge billing codes. All right. And again, it's easy for me to sit and say this, and I will tell you, but I can't tell you how you are able to get this information, okay, other than looking at the chart. Okay, ED departure time. Okay, seems like relatively simple. What's the time the patient departed from the emergency department? Notes for abstraction you want to read because it tells you what to do. It's the time the patient physically left the emergency department. Okay, don't use the time the discharge order was written because they could be sitting there for another hour or two. Okay, read through instructions. What if they go to observation? Tells you your acceptable data source, but that's your whole ER record. Tells you what you can use. ED leave time is okay. If any of these wording like this is okay, don't use words like this. Okay, so they've got inclusions, they've got exclusions. This is the big one where I've used the same example every time, so I'm sorry if you've heard it. But I was doing an abstraction for accuracy with the hospital. And so I was looking at their records, and then I was seeing, you know, what they abstracted. And I'm looking at their record. They printed out a copy for me. And I found 4 different ED departure times. Okay, well, you're one person and you can't leave the ED at 4 different times. Okay. So which is the right one? Okay. So we had to have a discussion. Looking at my instructions. Okay, what I want the earliest, I want the physically left the department, I want this. But we had to have a chat, you know, and say, okay, you've got in this EHR 4 different times with verbiage that says left the ED departure time. So who's entering that in your EHR? Okay, so the hospital had to go back and check out who's filling in that information. What, you know, again, you don't leave the ED 4 times. So who's putting in that information? What is the most accurate time? Again, an example of where you are responsible for putting the time. You want the correct time to put the time that really reflects how long was that patient in the ED. Some of these are pretty, you know, fibrinolytic date and time. If it was given, you know, they want the date, they want the time. That one's pretty easy. This one I always want to show. And I would say I've been abstracting for as long as there's been abstracting. Okay. I don't have these, and that's like more years than I want to say. If I'm abstracting a chart and I've got to answer this data element, I have to come here and look at these questions. So, and I just want to say, if I have to do it, I'm thinking pretty much that you guys as abstractors should be coming back and looking at this as well. Okay, this is a step-by-step. Is there segment of ST segment elevation on the ECG performed closest to emergency department arrival? It's just a yes or a no answer, but there are pages of instructions on when you can say yes, when you say no, what's an inclusion, what's an exclusion. Okay, I mean, we don't have to read the, you know, we don't have to read the graph, but we've got to look at the interpretation. And it's a step. Find the first one, perform closest to arrival. We want a signed one. Start with the signed one. If there's no signed one, what do we do? Okay, what are we looking for? We're looking for exclusions. If there's this, if there's that. All right, step by step. This is a pretty, I'm not saying there are some, every data element is important, but this one, how you answer this one, will often determine what other questions you have to answer. Okay, so for what I mean by that is when you're answering questions, and I always use the card tool kind of as my example because that's the tool I know, but the way you answer one question might determine if the other questions are grayed out for you or not. And this is a big one that determines whether you have to answer more questions, is to do if you're doing this one correctly or not. Okay, and this has nothing to do with the fact that the hospital, that the physician might say this patient had a STEMI or this patient had a non-STEMI or whatever the diagnosis is. Okay, if you've got an AMI record because it meets those three population requirements, you've got to answer this question based on these instructions. Any questions about that? Let's see what, I always like to point out this one too. Transfer for acute coronary intervention. Was there documentation the patient was transferred from this facility's emergency department to another facility for acute coronary intervention? Yes. Then 2, if they went to observation status prior to transfer, which that's pretty easy to determine. Or no, there was documentation the patient was transferred to another facility for reasons other than acute coronary intervention, or the specific reason for transfer was unable to be determined from medical record documentation. Okay, notes for abstraction. To select value 1, the documentation must specifically have a defined reason for transfer, such as they're going for an angioplasty, they're going for a cardiac cath, they're going to the cath lab, they're going for a PCI. Okay, if your record says transfer to general hospital, just because, and you know that we always transfer our cardiac patients to general hospital, that's not transfer for a specific acute coronary intervention. Okay, they want to know that patient is, and maybe you don't know yet. Okay, maybe that's not been decided yet. They're just being transferred because maybe they are going to the cardiac unit. Okay, but again, that's not a specific intervention. So that would be the value 3. You use value 1 only if it specifically says going for a cardiac cath, going for a PCI, going to put in a stent. I don't, you know, that there's an intervention is happening. Otherwise, you use the 3. Okay, here's some of the things that you're looking for. That's acceptable. Again, you're looking for some kind of intervention. They're going to do something, not just you're sending them because you don't have a cardiology department. Does that make sense? Oh, maybe I shouldn't put it that way. Is that clear? Some of these things that maybe don't make sense. I'll be the first to admit, but okay. So we went over how to determine your population for the outpatient measures in the Mbqip program. You know how to do your sample. Here are some of the data elements that might, sometimes cause trouble. Anybody have any questions? We've got about 5 minutes. Anything in the chat, Jody, or any questions that maybe I missed going over something, or?
There's nothing in the chat, Robin.
Okay. No questions from anyone. You can put it in the chat if you don't want to speak. Otherwise, you can unmute yourself. Remember, if you have a question, somebody else probably has it too. There's no foolish questions. Okay. I would say this means I'm an excellent instructor then, but after I looked at some of the EDTC quizzes we did after the last one, it made me wonder a bit. So we're going to do the same thing after this one, you guys. For any of you that were on the EDTC training, Later today or tomorrow, probably tomorrow, because I want to look at the questions again. We've got a little quiz. So we would like you to answer those questions and send it back. And I just kind of want to make sure that, that there is an understanding. Okay. So I've got a question. So if we transfer out and have a shared record, can we look and see if a cath was done and then say number one? No. Okay. No, you don't want to, you want documentation from your ED while that patient is there. Great question. Let's see if I think if there's anything else. Again, we'll give you about a week to give back the quiz. We really appreciate that getting back, and Jody will send a link to an evaluation too. Again, we appreciate you filling those out. Otherwise, I just have to kind of guess that I got everything across. You know, it's really helpful to know that maybe, you know, if something didn't, you know, if people think that something was missed, or if I hear she talks way too fast, then I will try to slow down a little bit. Or, you know, anything that you guys think that you might like a little bit more. Any data element questions that you have? Kind of one last call for questions. I can't think of really anything. Again, I want to say that for the Mbqip program, it's the AMI and the ED-Throughput. If you are submitting for the stroke, really, you know, you look in that stroke section, you determine what your population is. You would look in that population and sampling section to see if you would have enough to sample. And then here would be your data elements for some of the stroke questions. So really the same process. Can we review reason for delay or not administering the fibrinolytic? So is there a reason documented by the physician for a delay in initiating fibrinolytic therapy after ED arrival? So this is going to be one where it kind of depends on how some of the other data element questions are answered as to whether you're even going to have to do this one. But they want delays, not system delays. Okay, so these so if there's a delay because there's an equipment problem or staffing problem, that's not acceptable. Okay, so they're looking for delays like how they have here, you know, the patient's on fibrinolytic, so they maybe have to want to rule out a bleed, or the patient's waiting for wants to consult with their family, or kind of medical reasons. Okay, not if there's technical reasons, then there's a problem there. So that's not, they don't really say that that's like I mean, it's a reason for waiting, but it's not a good reason. I don't see a lot this one anymore, because again, it kind of depends on whether a lot of places don't seem to be giving fibrinolytics like they used to, or and then the reason for not administering, again, it kind of depends on how some of those other questions are answered. But there's a contraindication or other reason documented by the physician for not prescribing. If the patient refused, that would be acceptable. If the patient was in cardiogenic shock, that would be. Or this one, if there's no reason. There's kind of a lot of instructions to go through. So now this is a great one just to show you for a minute. These are in yellow because these are different from the last manual. There might have been a different wording or some different contraindications. So sometimes new things in a manual will be highlighted in yellow. So any of these contraindications would be a reason for a documented reason for not giving. Okay. And I'm sorry, I'm a little bit over time. So I think that was maybe Lynn, who asked about that. If I did, Lynn, you can contact me outside of this and we can go over that easier if you'd like to go over that more. So I'm a little after 12. Any last call for questions? Otherwise, we wait to hear from Jody with the evaluation link and the quiz questions. And if you could maybe send those back by next Thursday, that would be great. And let me, okay, stop sharing for a second and pull up one final thing before you go. If anyone didn't know how to get a hold of me or Jody, here's our information. And thank you for attending the session. Have a good rest of your day.